Great.
Okay, hi guys. Thanks for organising. I've been asked to talk about the abdominal radiograph. I've kind of pitched this at final year students preparing for finals. So for those of you who are a little bit more junior, this might be sort of more complex than you'd like, but just sort of bear with me if you can. As Olivia said, I think it's important to have a structure when you look at these things. There's no correct or best approach, but you need something that will allow you to not sound educationally subnormal when you are going through a difficult case. It's something to help keep you focused in the midst of a stressful exam. I found talking to the mirror quite helpful, just sort of presenting out loud to get yourself in the right headspace. This is an example of a structure that you can use to interpret abdominal radiographs. Abdo X, so A is air where it shouldn't be, i.e. outside the bowel. B is the bowel, D is densities, so mineralized lesions like gallstones, renal calculi, the bones, and then O, the organs, so the soft tissue silhouettes, which are poorly assessed on abdominal radiographs anyway. And then the X is for external objects like medical devices and foreign bodies. Again, you can use whatever system you like as long as you have a structure. The main indications in the acute setting are bowel obstruction and in patients with a flare of IBD to rule out toxic megacolon. Those are essentially the only two reasons you should be requesting abdominal radiographs in the acute setting. There are some other indications like follow-up of renal calculi, but these are very much small print. They are not useful if they're used indiscriminately. And this is good news because it means there's not that much that can come up in exams. So let's just go through the basics. This is a normal radiograph. Highlighted in red here is the colon, the large bowel. So you have the A. Can you see my pointer, by the way?
Yes, we can, yeah.
Okay, so here you have the ascending colon and the descending colon. And remember that these are retroperitoneal structures. So they're in a fixed position, held in place by a layer of parietal peritoneum anteriorly. So these are usually reliably on the right and the left. In contrast, the transverse colon and the sigmoid colon are both intraperitoneal structures. And what that means is they have a mesentery that connects them to the posterior abdominal wall, the sigmoid mesentery and the transverse mesocolon respectively. Therefore, they're a bit more mobile and the position is slightly more variable. This is another normal radiograph with some of the large bowel highlighted again. And the small bowel tends to be more central. So we mentioned as part of O, organs, assessment of the soft tissue silhouettes. These are very poorly assessed on abdominal radiographs, but you should look for them anyway. This is a really nice diagram that outlines what you should be looking for. So you have the liver in the right upper quadrant, the spleen in the left. You've got the kidneys at about the L1 vertebral level. And then the bones as well. So you have the vertebral bodies, you have the pedicles here in blue, the transverse processes and the spinous processes. You've also got the sacroiliac joints and the femoroacetabular joints bilaterally. The psoas muscle here is outlined in red. And when you're on your D part, your densities, you'll be looking for things like gallstones and renal stones. And when you're looking for renal calculi, you should follow the course of the ureter. And a good marker is the edge of the transverse processes of the lumbar vertebrae. So if you follow that down, you'll be pretty much on the line of the ureter. And remember, they insert into the base of the bladder posteriorly at the level of the ischial spines, which is this thing here. So I'll just take those highlights off and just try and get in your mind. So you've got liver up here. You can just about see the kidneys. You can see the psoas muscles. But again, it's all very poorly assessed using this modality. Okay, so how would I present this in an exam? So I'd say something like, this is an abdominal radiograph. The bowel gas pattern is normal. There's no evidence of perforation, and we'll discuss the findings associated with perforation later on. There is a ovoid mineralized density in the right upper quadrant that could represent a gallstone. The soft tissue silhouettes are normal. There are no medical devices. In summary, this is a radiograph which is essentially normal, bar an incidental gallstone. So something like that. What the examiner wants essentially is to know that you have a sensible approach and that you can work through an abdominal radiograph. Because the applications are so limited, you only need to know a few specific things, and we'll discuss those here. I don't know how your finals or OSCEs or whatever work, but where I trained, we had a dedicated images station where you would specifically discuss imaging, but radiographs also appeared in the clinical station. So you'd examine a patient, the examiner would ask you questions about your examination and then show you a radiograph. And in both cases, it would lead to a discussion of further investigations and related pathology. So, keeping it festive themed, I've done the 12-ish radiographs of Christmas. Each of them have an abnormality, and we'll discuss what the abnormality is and the related pathology. Some are more difficult than others. I don't expect you to get all of the answers, but what I want you to do is, while we're going through them, try and focus on your own structure. So if you saw this in an exam, how would you present it? What would you say next? Put yourself in the position of a student being examined in finals. Okay, so number one, I'll just give you a few seconds to look at this. Have a think about how you'd work through it, what the abnormalities are, how you might present them. Okay. And number two, so again, have a think through this. What would I say about this if I was in an exam? How would I structure my presentation so that I sound like I've been to medical school? Okay, so we'll go through these in a bit more detail, but these show bowel obstruction. And as I'm sure you all know, bowel obstruction is a common cause of the acute abdomen. You've got 4 classic clinical features: pain, distension, absolute constipation, meaning no feces or flatus, and vomiting. Small bowel obstruction is much more common than large bowel obstruction. You'll all have heard of the rule of 369, so that's the upper limit of normal size in centimetres of the small bowel, large bowel, and cecum respectively. It's important that you identify the dilated segment of large bowel, i.e. whether it's small or large, because that has important diagnostic and therapeutic consequences. And remember that you're not only looking for the diagnosis, i.e. small bowel obstruction, you're also looking for complications. And the major complication of obstruction is perforation. We'll discuss the findings of perforation later on. As a general guide, small bowel tends to be more central, smaller. You'll see a lot of loops when it's obstructed. And you have the valvulae coniventes, which are these linear lines that I'll point out in a moment that run across the full width of the bowel lumen. Whereas in contrast, large bowel tends to be peripheral. You get fewer loops and obstruction, tends to be more dilated, and you have haustral markings. So remember, you have the taenia, the external musculature of the colon, that contracts and forms these segmental pouches of large bowel. And the markings are called haustral markings, and they just sort of indent the lumen of the bowel rather than running across the full width of it like the valvulae coniventes. Small bowel obstruction, the number one cause is adhesions. The most common cause of adhesions is previous surgery. So surgical history is hugely important here. Other inflammatory abdominal processes like Fitzhugh-Curtis syndrome or previous appendicitis or whatever can also cause adhesions. So that really is the big ticket item for small bowel obstruction. Hernias can also cause small bowel obstruction. Remember the definition, it's something like protrusion of a viscus through the walls of its containing cavity. Also inflammatory strictures in Crohn's disease. Malignant obstruction is much less common than in large bowel obstruction. So if you're asked for a cause of small bowel obstruction and you say malignancy, you wouldn't be wrong, but it would be sort of inappropriate to say that first. Adhesion should be the first thing that comes to mind. In contrast, in large bowel, the number one cause is cancer, so malignant obstruction. You can also get diverticular strictures or volvulus, most commonly in the sigmoid colon. So when you're interpreting these radiographs, not only do you need to sort of go through and explain your findings, but you need to move on and say what you would do next. So major management points for bowel obstruction: fluids, NG tube, CT scan. So at medical school, this was taught to us as drip, suck and scan. So they need IV rehydration, correction of electrolyte abnormalities. You need to decompress the stomach to stop them from vomiting and aspirating, and they'll need a CT usually to try and make a specific diagnosis. And remember, you're not being assessed on your ability to be a radiologist or a surgeon. The question is this person going to be a competent F1 and not kill somebody? And don't forget the basics like analgesia, etc., when you're talking about this kind of stuff. Cool. Okay, so that's quite a lot of non-radiology for a radiology talk. But now we'll go back to the radiograph. So what do you see here? Well, you've got lots of central dilated loops of bowel. If you measure these, they're more than 3 centimeters. And these are the valvulae coniventes we spoke about. So these markings that run across the full width of the bowel lumen, these are indicative of small bowel. You'll also notice there are some surgical clips here and here and here. So this guy has had something done to him previously. And as you will recall, adhesions are the #1 cause of small bowel obstruction. And the #1 cause of adhesions is previous surgery. So this is all fitting together nicely now. And this thing here, all these little markings, this is a mesh hernia repair in the right lower quadrant. So if I was in an exam, I would say something like, this is an abdominal radiograph. There are multiple loops of dilated bowel centrally with valvulae coniventes spanning the full width of the bowel lumen. This would be consistent with small bowel obstruction. There's no evidence of perforation. The bones appear normal. And then I would say there is evidence of previous surgery. Therefore, this is most likely adhesional small bowel obstruction. The adhesions being caused by previous surgery. Other common causes of small bowel obstruction include, as we've already discussed, hernias, inflammatory strictures. I would like to manage this patient by arranging IV rehydration, correction of electrolyte abnormalities, insertion of an NG tube, CT scan. So you describe the abnormalities, but then you go on to show that actually I know a little bit more than just how to look at a scan. So in contrast with this one, I would say something like, this is an abdominal radiograph. There are several dilated loops of bowel visible with haustral markings, which are these, spanning part of the width of the bowel lumen. This is suggestive of large bowel obstruction. There is no evidence of perforation. The lumbar spine is degenerate, and there is a left-sided hip replacement and a vaginal pessary. In summary, this is a abdominal radiograph demonstrating large bowel obstruction. The most common causes are malignancy, diverticular stricture, sigmoid volvulus. I would like to manage this patient by XYZ. Okay, so that's how you approach this kind of stuff. So bowel obstruction is going to be probably the most common thing that you'll see in your exams on an abdominal radiograph. And all you have to do is differentiate between large and small. We'll later talk about the findings of perforation, but that's that. Okay, so number 3, if I tell you this patient has ulcerative colitis, you should sort of start to edge closer towards a diagnosis. Now, it doesn't look like bowel obstruction because there's not a lot of dilated bowel, but there is this big single segment here. So in the context of inflammatory bowel disease, if I say that somebody has a single large segment, the diagnosis should be toxic megacolon. That's what you should say next. So that's an acute complication of IBD, most commonly ulcerative colitis, in which you get severe inflammation that leads to loss of neurogenic tone and dilatation of the affected segment. And it's high risk for perforation, okay? So, can I go back? Yeah, so this is what toxic megacolon looks like. I thought this was also probably a good opportunity to discuss the other findings of IBD on radiographs. So this one on the left here, the abnormality is in the descending colon. And this is something called thumb printing that I'm sure you've all heard of before. But you have these edematous, swollen mucosal indentations which occur in the context of acute inflammation. And it's like someone has sort of popped their thumb into the side of the bowel. So that is acute. This on the right is chronic. So this thing here is called lead pipe bowel, and it's this long segment of completely featureless transverse colon. This is the consequence of repeated episodes of acute inflammation. There's also, if you're working through your structure here, another clue that this patient has inflammatory bowel disease, which is that the SI joints are fused. So on the left here, you can see there's joint space, but on the right, that's all obliterated. And that's a consequence of an enteropathic arthritis, which is one of the seronegative spondyloarthropathies. And you get fusion of the SI joint. So if you were a really excellent candidate, you would describe this as evidence of chronic inflammation, most likely IBD. Supporting evidence is that the patient has fused SI joints. Cool. Okay. So this is a special type of large bowel obstruction. And this is one that you should eyeball and just know the diagnosis immediately. You can see there's this absolutely gigantic loop of large bowel with haustral folds, occupying almost the entirety of the abdomen. And there are some additional smaller loops of dilated large bowel elsewhere. So have a think about what the diagnosis might be. This does give the game away a little bit. So remember that the sigmoid colon, as we discussed earlier, has a mesentery. So it's held from the posterior abdominal wall by a double fold of visceral peritoneum. This means it's mobile, so it can flap around a little bit. In contrast, the ascending and descending colon, as we discussed, are held in fixed positions because they're retroperitoneal. This is the sigmoid mesentery in green. And the importance of this is that the sigmoid is slightly mobile. And because it's mobile and it's mesentery, it can twist. Twisting of the sigmoid colon is termed sigmoid volvulus, and you get something called the coffee bean sign. So apparently this looks like a coffee bean with the eye of faith. I think a lot of these signs require a little bit of a looking with the eye of faith. The reason you know this is sigmoid volvulus, apart from the massive dilated loop, the coffee bean sign, is that you have additional dilated loops of large bowel as well. So think about where the obstruction is here. So the sigmoid has twisted on itself and you get this massive dilated segment, but the point of obstruction is in the distal sigmoid colon. So all of the descending, transverse and ascending colon are going to dilate. So you also get these other dilated loops of bowel. So that is a sigmoid volvulus. So can you run a poll, please, from A to D? So what's the first line management of sigmoid volvulus in the acute setting? Just fire at will. Okay. Can we see the answers? Okay, yeah, so a pretty even split. The correct answer is C, flatus tube insertion. So this is also known as endoscopic decompression. And basically, if you can work a tube up into the dilated sigmoid loop, you can decompress it and it will automatically devolve. Sometimes the patients will need a laparotomy because that doesn't work. The decision about whether that's emergent or urgent depends on the clinical state of the patient. D, percutaneous endoscopic colostomy, is a way of managing people who have recurrent sigmoid volvulus but aren't suitable candidates for surgery. Sometimes you can fix the sigmoid colon laparoscopically or via open surgery. But this essentially involves creating a hole in the sigmoid colon with a stoma bag just to keep it permanently decompressed. But the first line management is flatus tube insertion or endoscopic decompression. Okay, fine. So number 5, have a look at this. Again, think through, what would I say if I was in the exam? What is the abnormality here? So we've just discussed sigmoid volvulus. Does this look like sigmoid volvulus, or are there features that would suggest another diagnosis? Or are there features that are incompatible with sigmoid volvulus? So it's tricky. This is something called a caecal volvulus. So you'll remember that the cecum is the most proximal part of the ascending colon. So how do we know, if we could run another poll please, how do we know that this is a caecal volvulus as opposed to a sigmoid volvulus? So remember we said that the sigmoid when it twists, the site of obstruction is at the distal sigmoid colon, so the colon, the large bowel proximal to that, dilates. So think about where the obstruction is with cecal volvulus and what the radiographic consequences of that might be. Okay, whenever you're ready. Yeah, great. So most of you got that right. So I'll just explain why this is correct here. So the point of obstruction is the cecum, so the beginning of the ascending colon. So you see this big dilated loop of cecum, but the distal colon, the large bowel, will all collapse down, so you don't see any of that. But because the obstruction is essentially at the level of the ileocecal valve, you have all these dilated loops of small bowel, remember, with the valvulae coniventes, peripherally. So this is how you know that this must be a cecal volvulus as opposed to a sigmoid volvulus, because if you had a sigmoid volvulus, you would have dilated loops of large bowel. Okay, this is a nephrostomy tube, but that's irrelevant to the findings. So it's much, much less common. You almost certainly won't see it in your exams, but it's just worth being aware that it exists. It tends to occur in younger patients, and basically the risk factors are people who have an abnormally fixed or unfixed, rather, ascending colon, or people who have had previous surgery and adhesions. Okay, so another radiograph, have a look at this. What would I say if I was in an exam? Okay. Have a look at this again. Same thing. What would I say if I was in an exam? These are both quite tricky. Okay. So these are both examples of perforation. Perforation is basically something that you mustn't miss. And it's a bit annoying because it's actually quite hard to see on an abdominal radiograph. It's much better demonstrated on an erect chest X-ray, which is the more appropriate test. So if you see someone in ED or whatever during your future career and you think they may have perforated, you should request an erect chest X-ray. They don't need an abdominal radiograph necessarily as well. But if you're thinking perforation, you should never request just an abdominal film because it's much harder to detect. If you think about it, air rises up, layers under the diaphragm, and you can easily see pneumoperitoneum on a chest X-ray. But for the sake of the talk, we'll discuss the radiological signs of perforation on an abdominal film. There are loads and loads and loads. And if you go on Radiopedia, I mean, the list is just absolutely endless. But I think these are probably the most frequently encountered. You should have heard of Wriggler's sign, the double wall sign. Now, this took me ages to get my head around at medical school, and I just didn't quite get it. So I'm going to linger on this for a bit and just bear with me if you find it boring. So normally, when you have a normal segment of bowel, you can see, so this here is the descending colon, and this is normal. This is an example of intraperitoneal air, and remember the descending colon is retroperitoneal. So you can see air within the lumen wall interface, and then the wall just kind of blends into the abdominal fat. Whereas, and that is normal. Whereas, because there's free intraperitoneal air here, you have air within the lumen wall interface, you go across the wall, and then you have a sort of wall external surface interface. You can see the external margin of the bowel wall. And that is Wriggler's sign, or the double wall sign. And if we throw up these two for comparison, so this is the one we encountered earlier, the small bowel obstruction. You look at the bowel here, you've got air within the lumen, you follow the lumen out, you have the lumen wall interface, here's probably a better example, and then it just kind of blends into the abdominal fat. You can't really make out the external margin of the bowel wall as a separate layer. Whereas here, you can quite nicely go lumen wall, across the wall, and then wall external surface, because there's free intraperitoneal air. So you can see the external margin of the bowel, but it can be really difficult. Okay, so that is the Wriggler's sign. There's also something called the cupola sign, which is an architectural term. So there's obvious pneumoperitoneum here, which is why you should always be requesting an erect chest if you're worried about perforation. But you can also see this sort of radiolucent line here, and that is air under the central tendon of the diaphragm. So if on an abdominal radiograph you didn't have the, it didn't extend high enough for you to see the diaphragm, you might see the central tendon, and you might be able to see this sort of linear cupola-like lucency, which is indicative of air under the central tendon of the diaphragm. There are a couple of signs that you see basically exclusively in children, the football sign and the falciform ligament sign. So the football sign, this is a child with an abdomen full of air, and it apparently looks like an American football with the eye of faith. There's lots and lots of free intraperitoneal air. And you'll remember that children, particularly in premature neonates, the most common cause of pneumoperitoneum perforation is necrotizing enterocolitis, or NEC. And this is the football sign here. Whereas this is the falciform ligament sign. So this is another premature child, probably with NEC, who is perforated. And they have this linear opacity here, which doesn't look quite right. And this is the falciform ligament. And Olivia talked briefly about the silhouette sign. So the only reason you can see this now is because there's air on both sides. So there is a density difference, whereas normally it's surrounded by normal fat and obliterated and you can't see it. Whereas because you now have air on either side of the falciform ligament, you can see it on a plain film. And you'll remember that the falciform ligament connects the liver, which is here, to the anterior abdominal wall. Okay? So those are probably the four main signs. Wriggler's sign is certainly the most important and the one that you'll hear discussed most frequently. I'm going to give you a bonus sign here that you don't need to know about, but I'm just going to talk about it because it's my personal favourite radiographic sign. So this is a guy called Doge Loredan. The Doges were sort of Italian functionaries who wore these special hats. This is painted by Bellini. It's in the National Gallery if you want to go and see it. But they wore these slightly unusual caps. And you'll remember from your anatomy that there's something called Morrison's pouch, or the hepatorenal recess, which is between the liver here and the right kidney. And sometimes in perforation, you can get air collecting in Morrison's pouch, which is this arrowed black thing here. And that looks like this. And apparently that looks like the Doge's cap, the pointy bit of the cap. I know, talk about the eye of faith. This will almost certainly never come up, probably in your entire careers, unless you do radiology, but I think it's quite a fun one to know about. Okay, so let's leave that behind. So those are the radiological signs of perforation. Must be aware of those. Obstruction and perforation are going to be the big boys in terms of getting marks in your OSCEs and finals. Okay, so number 8, have a look at this. What do you think? Where's the abnormality? What might it be? I've deliberately used this one because it's a bit difficult. And I don't think you'd be expected to get the answer. But if you see something like this, something trickier, A, it's usually a sign that you're doing well because they're showing you something harder. And B, it's because they want to see how you cope under pressure or in the context of something you're unfamiliar with, which is why having a structure is so important. Because if you approach this and you know it's abnormal, but you don't know why, and you just sort of blather blindly, you're going to lose the confidence of the examiner. But if you sort of work through it systematically, you might say enough in a sensible way that they'll still think you know what you're talking about. So this is an example of pneumoretroperitoneum. So there's pneumoperitoneum, which is air within the peritoneal cavity, and then there is air in the retroperitoneum, so behind the peritoneal cavity. So this relies on your knowledge of anatomy. You see air outlining the retroperitoneal structures, which you will remember SAD pucker is a useful acronym for identifying those. There may also be associated pneumoperitoneum, but not always. Pneumoretroperitoneum is always abnormal. Just a basic refresher for our anatomy. So this is the peritoneum, the parietal peritoneum that lines the peritoneal cavity. Pneumoperitoneum is air within the peritoneal cavity. Behind the parietal peritoneum is the retroperitoneum. So the kidneys, IVC, aorta, etc. are all here. The ascending and descending colon are also retroperitoneal. And this kind of shaggy lucencies and a slightly weird distribution, sort of outlining the kidney, psoas is easily visible here, coming around the liver. This is abnormal, and this is pneumoretroperitoneum. But that's very difficult. So if we could chuck up another quiz. This is a hard one. Which part of the bowel, or parts of the bowel rather, are retroperitoneal? This is a difficult one. Okay. Yeah, nice. So I think you're sort of converging on the correct answer here, which is D. So the duodenum has 4 parts, 1, 2, 3, and 4. The first part is intraperitoneal, and you'll remember what that means is that it has a covering of visceral peritoneum and is suspended from the posterior abdominal wall by a mesentery, a double layer of visceral peritoneum. Whereas the second, third, and fourth are all retroperitoneum, as well as the ascending and descending colon. So B and C is the correct answer. D. Okay. And therefore, causes of retroperitoneal air must involve perforation of D2 to D4 or the ascending or descending colon. So the most common causes are a perforated duodenal ulcer. Endoscopy is a common cause. So they're putting a camera down the stomach, around the pylorus and into the duodenum, and if they're manipulating it there, there's a possibility that they will perforate. ERCP, so endoscopic retrograde cholangiopancreatography, which is essentially the same as an endoscopy, but what they try and do is cannulate the ampulla of Vata, which is where the main pancreatic duct and the common bile duct empty into the duodenum. So they go down with an endoscope and then try and insert a small device through the ampulla to perform biliary interventions, usually for gallstones, but there are lots of reasons why they might do this. And the risk of perforation is higher with ERCP, particularly when they perform something called a sphincterotomy, which is where they try and open up the ampulla. Anything that perforates the ascending or descending colon will give you retroperitoneal air, and it can also happen in trauma. So the ligament of Treitz runs from the posterior abdominal wall, sort of around the celiac axis, which you'll remember is the first visceral branch of the abdominal aorta, and connects to the D3-4 junction. And if you're, say, in a car crash and you're going forward at speed and you suddenly stop, your bowel moves forward, but the ligament is fixed. And so the bowel can shear at the point at which it attaches to the ligament of Treitz. So the D3-4 junction, you can get a deceleration injury there. So these are the causes of retroperitoneum. This is very small print, but it's just useful to be aware of and know that it exists as an entity. Okay. Number 9. So have a look through this. What would you say if you were in an exam? How would you go through it? Okay, I hope a few of you have spotted the abnormality. Don't worry if you didn't, it's subtle. So you remember earlier that we discussed the kidneys, so you can see the outline here, just perhaps that behind the colon. And you'll remember that the ureters run along near the edges of the transverse processes of the lumbar vertebrae. Okay, so you'll follow as part of your O section, your review of the soft tissue silhouettes, or part of your D section, however you break it up, you follow the ureters down and then insert at the level of the ischial spine, which is about here, so you haven't included the bladder there. But as you come down, your eye should be drawn to this, and this is a calculus. So that's just re-illustrating what we looked at, yeah? So you can see that quite nicely there in the region of the course of the ureter. Okay, right. So remember, we said earlier that abdominal radiographs are not appropriate to use in the acute setting. For diagnosis, the patient should have a CT KUB, which is a non-contrast CT of the abdomen and pelvis. They might be seen incidentally or on interval monitoring scans. Sometimes urology requests them to monitor calculi. Most renal calculi are radio-opaque. So the most common two types of calculi are calcium oxalate or phosphate or struvite. Those make up the bulk of renal calculi, and those are radio-opaque. The radiolucent stones, uric acid and cysteine, are much less common. Okay, you could be asked quite a bit about renal calculi in your finals. You know, they might show you a radiograph like this and then launch into a discussion about risk factors, investigation, management, etc. And I'm not going to discuss all that here because that's really a separate topic, but I will brush over some high yield factoids that seem to come up again and again in exams, both written and clinical. So if we could have another poll, please. What type of stone causes this appearance? So if you were listening about 15 seconds ago, you should be able to eliminate two of these immediately. Yeah, very good. Shame on you that voted C and D. Remember, these are radiolucent, so you wouldn't be able to see them anyway. So it has to be A or B because those are the radio-opaque types of stone. And the vast majority of you have got this right. The most common cause of this type of stone is struvite. This is known as a staghorn calculus, and it's this extensive branching calculus filling the pelvic calyceal system. So struvite causes the majority of staghorn calculi, but what predisposes to the formation of struvite stones? So another poll, please. Thank you. So this would be the follow-on, if you were in an exam, to the question. So you've got the mark for identifying that staghorn calculi are caused by struvite stones, and now you're trying to get the gold medal by giving the even better answer as to why that happens. Okay, great, yeah, well done everybody. So it's because of infection with urease producing bacteria like Proteus or Klebsiella classically. These are all wrong, I think. Briefly, urease generates ammonia from urea, which raises urinary pH, and an alkaline environment is conducive to the formation of struvite staghorn calculi. So this is staghorn calculus, classically struvite, caused by infection with urease producing bacteria like Proteus or Klebsiella. Now this is really an outrageous question for medical students, but I'll be very impressed if anybody gets the answer here. There's a certain type of HIV medication that precipitates in the urine and can cause radiolucent stones. This sometimes comes up in EMQs. If you could chuck up a poll. I don't expect anybody to get the answer here because it is a really tricky and unfair question and arguably completely irrelevant to being a functional F1. So far at will, have a guess. Yeah, pretty much what I expected. Good effort. The answer is D. So apparently indinavir can precipitate in the urine and cause radiolucent stones, but that is incredibly small print. But well done for those of you that got that. Okay, so we've discussed renal calculi. Now we're moving on. Have a look at this. What would I say if I was in an exam? How would I go through this? whatever structure you use, whether it be Abdo-X or something else, what am I going to say to the examiner? Okay, so hopefully you've spotted these mineralized densities in the right upper quadrant. You remember that this is the liver, and what sits under the liver? The gallbladder. So these are gallstones. So in contrast, it's kind of the opposite of renal calculi. In only 20% of gallstones are radio-opaque, so you're not likely to see them on abdominal radiographs, and you're also therefore not likely to see them on CT. So what is the best test for gallstones? I'll explain in a moment why this is an unfair question, but there is really one answer that you should be picking for exam purposes. Perhaps it would be better if it said, what's the first line test? Yeah, so C is probably the most correct, but everybody else is kind of right as well, and I'll explain why. So MRC, this is, including both of these, is sort of a quiz of what you actually know about imaging. MRCP is a type of MRI. It's essentially a very heavily T2 weighted MRI, and you just see fluid or stationary fluid, i.e. bile. So it's a good way of imaging the bowel. So A and B are essentially the same thing. MRCP is just a type of MRI. ERCP, as you'll remember earlier, endoscopic retrograde cholangiopancreatography, is an endoscopy, and additionally where they cannulate the ampulla, sometimes to remove gallstones in the CBD or to do whatever. But really, the exam answer is ultrasound, because with gallstones, you will see them on ultrasound. You can measure the size of the CBD, you can look for signs of cholecystitis, etc. It's generally cheaper, easier, quicker than MR. If you can't see anything on ultrasound, then usually you would go on to do an MRCP. So perhaps best test, I've phrased this poorly. The first line test really should be ultrasound. Okay. And another thing, a bit like Wrigley's sign, that for some reason just didn't go into my brain at medical school, was the difference between all these these four things. And I'll just touch on them briefly here. It's not really relevant for the radiology, but it's just kind of being a functional student. Biliary colic is postprandial colicky, i.e. intermittent pain, that classically comes on in the right upper quadrant after eating meals with a high fat content. Inflammatory markers are normal, no fever. Cholecystitis, usually, and this is due to gallstones, so it's due to the gallbladder contracting around the gallstones, causes pain. Cholecystitis, in contrast, is usually the result of a gallstone becoming impacted at the neck of the gallbladder, resulting infection, inflammation of the gallbladder itself. So you get continuous right upper quadrant pain with fever, raised inflammatory markers. Okay. Ascending cholangitis, on the other hand, sort of refers more generally to infection of the biliary tree, usually the intrahepatic biliary tree. And if you have, so this is almost always caused by a gallstone stuck at the neck of the gallbladder. This is often caused by a gallstone that's migrated into the common bile duct and is obstructing the whole biliary system. This is a really nasty entity. Pancreatitis, on the other hand, you'll remember that the most common cause is gallstones. In the eye gets smashed mnemonic, aside from idiopathic, and that's just localized inflammation of the pancreas. So it's just worth having the differences between these in mind. This may seem super obvious to everybody here, but for some reason I struggled to kind of understand that for ages. Okay, this is really outrageously tricky. And we're getting towards the end of the talk now, so we're just sort of enjoying ourselves. I'd be very impressed if people get this. The game is slightly given away by the fact that we're talking about gallstones. If you could chuck up a poll, please. But just think, if you were looking at this in an exam, what would you say? How would you get around this? You don't know, for the sake of argument, what the diagnosis is, but you're just trying to describe it in a way that makes you sound sensible. Okay, if we could end the poll. Yeah, gallstone ILEUS. Yeah, well done. So this is really, really hard. I'll go through the imaging features in a second, but essentially this is due to repeated bouts of acute cholecystitis, and the recurrent inflammation results in the formation of a fistula between the gallbladder and the duodenum. And that's called a cholecystoduodenal fistula. And it allows gallstones to pass through the fistula into the small bowel. They usually migrate around the small bowel and then get stuck at the ileocecal valve, which leads to small bowel obstruction. And the radiographic features are Rigler's triad, which is distinct from Rigler's sign. Rigler's triad is small bowel obstruction, which is obvious here. So hopefully by now you'll all know that this is small bowel obstruction. You've got the valvuli coniventors running across the full length of the bowel lumen. The bowel is obviously dilated. So if you didn't know what the hell was going on, you'd say small bowel obstruction. Hopefully some of you would have spotted this calcific density down here. Small bowel obstruction, calcific density here, I don't know, discussed in my senior CT scan, etc. You discuss the common causes of small bowel obstruction, the management, and that would get you out of hot water. But if you get the diagnosis, that's great. So this up here, this kind of branching lucency is pneumobilia. It's really tricky to see, especially on this rubbish radiograph. But in the same way that gallstones can go from the gallbladder into the duodenum, air can go from the duodenal lumen into the biliary tree. So Rigler's triad involves small bowel obstruction, pneumobilia, and an ectopic calcified gallstone, usually in the right lower quadrant, impacted at the ileocecal valve. So if you put all that together, that really would be astounding for any medical student. That's very tricky. But again, like pneumoretroperitoneum, it's good to be aware that it exists because it comes up far more frequently in exams than in real life. Okay, getting towards the end now. Have a look at this, have a think, what would you say? What's the diagnosis? Work through your structure. Just think, if someone right in front of me now, how would I describe this? What would I say? Remember, the key is when you don't know the answer, to stick to some sort of sensible system and just describe. Okay. Yeah, can we end the poll? Yeah, well done. So this is hardish, but you can see there's this calcified ovoid structure here. So remember, the IVC runs on the right and the aorta runs slightly to the left, which is where this is. They've got vascular calcification elsewhere, if you follow my pointer. They're also quite old and generally crumbling. But this is a peripherally calcified abdominal aortic aneurysm. And if this is identified for whatever reason, they will then need to go on to have proper imaging, whether that's a duplex or an aortogram. This, I just wanted to throw up so that you've all seen it, is a method of treating abdominal aortic aneurysms. It's called an EVAR, or an endovascular aneurysm repair. And essentially what they do is they put this stent from normal aorta. The aneurysmal segment will be here, so ballooned out there, and the blood will run through the graft and then via the iliac limbs into the common iliac arteries and more distally. And the idea is that you exclude the aneurysm sac, which then thromboses off, clots, and this is put in by interventional radiologists. So this is probably the way that most aneurysms are now managed. Open surgery used to be common, but the outcomes are pretty much identical. And a lot of people who have AAAs aren't suitable for open surgery, but are suitable for EVAR because all it requires is a groin puncture. Okay, cool. So number 12, this is getting on to the last one now. In fact, I think this is essentially the last section. So again, what would I say if I was in an exam? The theme here is densities, calcified things, external devices. Again, much of this talk is just make sure you've seen it before so that if you see it again, you'll know it. Okay. So there's a lot of bang for your buck in this one. So you can see surgical clips in the right upper quadrant. So if you remember, if I showed you a calcified lesion here, you would say it was a gallstone. So this is going to be cholecystectomy clips from a lap chole. Surgical clips, always really important to identify, especially if you see something like obstruction, because then it's going to give you a clue that perhaps it's due to adhesions if it's small bowel, or perhaps they've had a previous cancer operation which has then recurred if it's large bowel. You've probably also spotted this. So in your densities part of your review, you'll look at the bones and you'll see there are these hyperdense, fluffy abnormalities in the vertebral bodies. And this is vertebroplasty or kyphoplasty. It's a way of treating osteoporotic vertebral fractures. And you inject this cement essentially into the vertebral bodies to prop them up. There's also this cage-like thing. So you'll remember that the IVC is to the right and the aorta is to the left. So this is something called an IVC filter. So in somebody who has DVTs, you would normally anticoagulate them, but let's say, for example, they're a trauma patient and they've also had a subarachnoid or something, and you can't anticoagulate them because of the risk of further bleeding. Then you would ask your kind interventional radiologist to put in something called an IVC filter, which is designed to basically catch the clots coming up from the legs before they become pulmonary emboli. So that's an IVC filter, that's what it looks like. You can sometimes get ones that kind of look like an upturned umbrella, but it's basically a cage-like structure projected sort of slightly to the right of the midline. And then this little guy here is a capsule endoscopy. You will rarely see these, but there are lots and lots of sort of weird and wonderful things that can appear. It's probably less complex than chest, where there are all sorts of weird Swan-Ganz lines and mad stuff that can you can encounter, but it's just worth seeing these once so that you know what they are. Okay. And you should be aware that you can also see these on chest x-rays. So this, I don't know how well this projects, but they've clearly had a vertebroplasty here. Okay. Other bits and pieces, shoulder stuff going on as well. So, but is there another finding there? So if we just go back to this one, a test of how well Olivia's taught you. Have a quick look through the rest of this and see if you can see anything that just doesn't look right. And again, this is another very tricky one that I don't expect you to necessarily get the answer to. So perhaps some of you will have had your eyes drawn to the right upper zone and these slightly dense things that kind of look like vascular markings, but are just sort of wrong. And what this represents is embolized kyphoplasty or vertebroplasty cement. So there's a venous plexus around the vertebrae, and if the cement escapes into the venous plexus, it will fly off, and then as it goes through the heart, will go into the pulmonary vessels and will embolize distally. So it's effectively the same thing as pulmonary emboli in terms of its clinical impact, but there is no way of treating this. You can't anticoagulate because it's not thrombus. It just sits there, and that's game for that little bit of lung that's supplied by these arteries. So this is known as vertebroplasty cement embolization. Again, very unusual, but worth knowing that it can happen. The reason I bring this up is because of something called satisfaction of search, which is a category of radiological error. And just because you found one thing doesn't mean there's nothing else to find. So it's like if you're looking through a load of radiographs for a trauma patient, you might see an abnormality and go, oh, okay, they've got a fifth metacarpal fracture, I'm going to stop looking. But actually, they've also got a scaphoid fracture and a base of first metacarpal fracture, blah, blah, blah. So my advice to you is, once you've decided on a structure that you're happy with, if you find an abnormality in that particular part of your review, so for example, if you see bowel obstruction under B, go, okay, there's small bowel obstruction, I'm just going to put that to one side, and I'm going to continue to go on to D for densities and see if I can find anything else. Then I'm going to, and then let's say you see something abnormal in D, again, put that to one side, continue to O as if you hadn't found anything abnormal. So you've got to make sure that you look through every single thing in your review framework. And this is part of the reason that a search strategy is so helpful. Okay, thank goodness that's over. I'm aware there's a lot of information there, but I hope some of you found that useful. The take-home points are that you need some sort of structure for various reasons. You only really need to get the major abnormalities. They're not going to expect you to pick up stuff like pneumoretroperitoneum or small bowel gallstone ileus, but they will expect you to identify small bowel obstruction. They will expect you to identify large bowel obstruction, and they will probably expect you to identify pneumoperitoneum. They will also expect you to suggest causes and further management. So remember that when you finish talking through a radiograph, your job is not over. In an exam, you're looking to score points. You're looking to get as many marks as you can. It's like an interview where no matter what the question is, you just kind of crowbar in all the stuff that you've done to show how brilliant you are. And so if you see a classic, uncomplicated, i.e. no perforation, small bowel obstruction, not only do you get the diagnosis by presenting beautifully, you will then go on to say the most common causes are X, other causes include Y and Z. In terms of management, I would do X, Y, and Z, just to show that you're sort of thinking holistically like a doctor and not like a machine that reports radiographs. Okay, so I hope that was somewhat useful. If you have any questions, feel free to put them